I'm very happy to introduce Dr. Scott Walters, who will speak to us. His presentation is titled National Opioid Crisis, Causes and Solutions. Dr. Walters is a Regents Professor of Health Behavior and Health Systems at the University of North Texas. He received his bachelor's from Biola University and his master's from SDSU, woo, go Aztecs, and his Ph.D. in clinical psychology from UNM. Dr. Walters' research looks at ways to use motivational interviewing and technology as behavioral health interventions. His experience includes brief interventions for underage drinking, adults in the criminal justice system, heavy drinkers in hospital settings, people at risk of cancer, genetic disorders, community-based health navigation, and what's missing from his bio is also work with homeless populations, which I think really is notable and important to talk about as well.
So I want to start in a place, this is Portsmouth, Ohio, population 20,000. We're looking east here toward West Virginia. You got the Ohio River just off camera on the right, and you got Kentucky further to the right there. It's very pretty downtown. It's very walkable. This is Shawnee State University, a little university there. You got a couple lofts. You got a nice coffee shop down there. If you're ever there, I suggest you walk down the river, kind of on the right side of the screen there, and come up through this wall here, which you can't quite see, is a series of murals about the history of the town. Very interesting little place. In the early 20th century, there were 100 different manufacturing companies here, including the fourth largest shoe manufacturer and the largest manufacturer of paving blocks in the US. Fast forward 80 years, in the early 2000s, Portsmouth becomes an unlikely ground zero for the opioid epidemic. In Scioto County, where Portsmouth is located, nearly 10 million pills were prescribed in 2010. There's no need to check your speakers. 10 million pills were prescribed in 2010, enough to give 123 pills to every resident in that county. Matter of fact, nearly 3.4 billion pills flooded into Ohio in 2006 through 2012. As a consequence, it's estimated that more than 100 million years of life were lost in Ohio due to drug overdoses in that decade between 2008 and 2018. So that means each of the 26,375 people that died from an overdose lost on average 39 years of their life. It's important to recognize that none of this happened by accident. In Portsmouth and other towns like Portsmouth, the opioid crisis unfolded in 3 different waves. We usually talk about the opioid crisis, but really we're talking about a series of crises here, and sort of in 3 waves. Deaths from prescription pills showed an increase starting around 2000. And then the second wave, an uptick in heroin-related deaths was around 2010. And then what you see is a third wave there in the overdoses that currently is driving most of the deaths is through the synthetics, fentanyl and the other synthetic opioids. Now, as deaths from you can see the purple line there, the simple pill deaths have flattened. Fentanyl has pretty much taken over, and as a result, more and more years of lives are lost. So again, you have the 3 waves. You have, first of all, a pill wave starting in 2000, which as we tamp down on the pill wave, you start to see an increase in heroin. And then as we tamp down on heroin, you start to see an increase in the synthetics that are being released, resulted in a much more deadly and volatile supply. Starting in about 2018, deaths had fallen, actually starting in 2017, for the first time ever. You can see opioid overdose deaths took over motor vehicle collisions in terms of the likelihood, the cause of death. That was a result of a decrease in fatalities from motor vehicle collisions, as well as an increase in fatalities from opioid overdose. So starting around 2017 was sort of, to that point was the peak, 2017, 2018. We had been seeing a decrease since 2018. So 2018, 2019 had seen somewhat of a national decrease. However, you might have guessed, last year we saw another spike as a result of the COVID-19 pandemic. Rates shot up in virtually everywhere to the highest rates ever seen. If you look just at the course of the year, most states peaked around May and have shown some reductions, but year over year, 2020 was the deadliest year for opioid overdoses. like many health behaviors, there's a disparity in deaths. It varies considerably based on geography. The base rate, the rule of thumb that we use, is a rate of about 15 per 100,000 nationally per year, overdose deaths per year, about 15 per 100,000 on average, but rates vary hugely, as you see here. States like Texas, for instance, has a somewhat lower rate. We have about 5 per 100,000 where I'm located. I don't know about Oklahoma's. Are you higher than the national average?
We are.
Yeah, okay. So you're working your way up from that 15 per 100,000. It's somewhat unusual to look at this map. So you see a sort of a clustering in the middle and in the kind of a rust belt, what we used to call the rust belt, in the kind of the east coast states, and a little bit through the sort of the mountain plains or sort of mid southwestern states here. But one interesting thing I'll just throw that out there. This doesn't really look like other health behaviors. That's the curious thing. It doesn't look like smoking. It doesn't look like, obesity, for instance. It doesn't look like alcohol. It's kind of its own thing. So we approach this by thinking of, we have to develop sort of a new way of thinking about what in the world happened if you have a new public health epidemic that doesn't really follow other sorts of public health trends. How did this occur? Well, one thing to just look at what we consider counties that are at high risk of opioid overdose, as judged by, you can see, having fewer primary health clinicians, having more unemployment, and having lower education. Those are three strong predictors of what they call opioid high risk counties. So you start to get a little bit of a story more of lack of service, of poverty, and more structural changes that we think account for a lot of this overdose. This is a kind of interesting reanalysis of this, using this map here, but it's a kind of interesting reanalysis, and it's worth just pausing and thinking about that. What they do in this analysis is they looked not by opioid overdose in general, but they looked by opioid overdose by drug class. And what they found is that we're seeing almost like three separate epidemics that we may be calling all just the opioid crisis. But it sort of depends on what different countries have been affected differently by opioids. So the blue areas are more of the traditional prescription-related deaths. So these are pill-related deaths here in the blue areas. And you can see this follows the more general narrative of counties tend to be less populated, they tend to be more remote, they're older, they're mostly white. And so you can see that kind of describes Oklahoma, I think, compared to the rest of the US here. It's, you got a lot of pills. That I think this is back in, this maybe in 2017 or 2018, so things may have changed there. But the blue areas are sort of the more typical story that you tell. The sort of what they call the deaths of despair narrative. And unlike heroin, prescription overdoses deaths seem to follow state boundaries. So it's interesting to look at, like Kentucky here. It basically stops at the edge of the state. And so it's sort of a curious, the boundaries of the pill deaths seem to follow state boundaries to some extent. Now, the brown and the purple areas are heroin and opioid, what they call syndemic areas, where it's just a mishmash of a lot of different opioid-related deaths. The brown areas, you can see, are clustered not around the, white, rural, unemployment. They're clustered, interestingly enough, around traffic corridors. Isn't that fascinating? So look at this traffic corridor. This is down by El Paso, and it goes up to Denver, and you see a lot of brown and a lot of purple. Here's a traffic corridor that goes from kind of Chicago down through St. Louis, traffic corridor. You got another big traffic corridor sort of area here. So it also is helpful to think about when you're talking about the opioid crisis, even the current crisis, you're really kind of talking about at least 2 or 3 different things that we're all lumping together. I'll skip that because this is not a Texas group, but guys can come up with your own. So it's important to recognize that none of this happened by accident. And after years of stable decline, so rewind back to the 1990s and early 2000s, after years of stable declines in opioid overdoses, deaths started to rise in the early 2000s. And the precipitant seemed to be a new class of long-acting opioid medications developed and marketed or just earlier in the 1990s. Just rewinding to Portsmouth, Ohio again. In the late, and their experience, in the late 1990s, Portsmouth residents noticed something interesting. There were a handful of out-of-town doctors had quietly moved in and set up pain clinics that attracted a long line of people who would drive for hours and hours from neighboring states, spend a few minutes with a doctor, and leave with a prescription for 40 or 80 milligram OxyContin pills. So whose problem was it? Imagine you're a resident of a small town. None of this smells right, you know, but whose problem is it, really? You know, you have out-of-town doctors, you have out-of-towners that come and get their prescriptions, leaving their money in town, in taxes, but taking the trouble with them, take the pills with them. And so people were sort of scratching their head, and nobody quite knew what to do. A lot of people chalked it up to kind of the, well, you know, this is people kind of living off the system, or this is sort of modern day moonshining, and hasn't this been around to some extent forever and ever? And so, you know, a lot of these little towns like that were puzzled by, what in the world would you do with this? A legal substance, you know, and so nobody quite knew what to do. So that's the situation a lot of these towns found themselves in. And this precipitant, like I said, seemed to be a new class of long-acting pain medications. Historically, opioid pills were used to manage acute pain. So people were recovering and they got opioids in a hospital. Perhaps they got a day or two or three, or at most a week, something like that. But in 1990, for instance, a guy named Mitchell Max published an article calling for a different approach to pain, saying that finally we have a new drug class, and this is a kind of medication that's safe to use for, you know, for years, for chronic pain, for years and years. So we'll dose it to people, they take it home, they take it every day, and you know, it's a way to help people who have chronic back pain or you know, other sorts of chronic pain to get back to work and to kind of live their best life. And in fact, in 2000, the Joint Commission Standard for Pain Management called for a different approach to pain, and now recommended treating pain as what they call the fifth vital sign. That's this one here. And so recommended that we should be, you know, treating pain. Pain should be one of the, medical providers obligated to ask a patient about their pain and obligated to help a patient to manage their pain. They were helped by a little known article at the time, this one here, that appeared in 1980 by Porter and Jick. The takeaway from this little, it wasn't really even an article, it was just a letter to the editor in the New England Journal of Medicine. And so the takeaway here is this were patients who were given opioids in a hospital setting, in a supervised setting. And the conclusion that they had is, as an underlined here, we conclude that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. So that phrase, the development of addiction is rare, became almost like echoed from the Joint Commission, from the pharmaceutical manufacturers, from the insurers, from people that stood to make money off of that. Interestingly enough, so I'm showing you the article here on the left. That was it. That's the article. It's really just a letter to the editor. And yet over time, this language was repeated more and more and more. It was called an extensive study, a landmark report, you know, very rare, virtually no risk for addiction, all citing this letter to the editor. Interestingly enough, one little sort of quirky piece to this story is that at the time, prior to around 2010, online versions of the New England Journal of Medicine weren't available, or they weren't available online. These older versions hadn't been scanned and added till around 2010. So anybody that wanted to look up this article would have had to go to the library stacks and actually flip through paper copies. So the whole idea of quality control was an issue here. So this played a big role in the promulgation of the opioid crisis. And the pain scale there. So along with temperature, pulse, respiratory rate, and blood pressure, all of a sudden you have a recommendation that doctors should be, the quality standards of a hospital suggested that doctors consider treating pain as the 5th vital sign. So asking patients, just in the way you would assess a respiration, blood pressure. Now you have this metric, which is on a 10-point scale, and patients that are rating their pain as more problematic, then it's part of the quality standards for hospitals suggest that doctors should go out of their way to help patients to move them back into the green zone there. Now, at the same time, from 1996 to 2001, a little-known pharmaceutical manufacturer called Purdue Pharma, you may know Purdue from the news. They've been quite a lot of places in the news recently. They developed a very aggressive marketing campaign, first of all, and also a very lucrative bonus structure that paid their pharmaceutical reps to essentially push these pills. So for instance, in '96, Purdue Pharma paid a total of $1 million in bonuses, but in 2001, they paid a total of $40 million. So it's a 40-fold increase payments to the representatives, including in some instances paying doctors for speaking fees, consulting fees, travel vacations to nice spots. At the time, there were a lot of ways to get money into the hands of physicians as well who were willing to prescribe this. And again, Purdue complained that the risk of addiction from OxyContin was extremely small. And they cited this article by Porter and Jick saying that less than 5% of people became addicted to this. So that was the claim. However, as it turns out, turned out quite a lot more than that. So their claim that less than 5% of patients who were prescribed opioids misused them. It turns out it's much higher than that. Something in the neighborhood of a quarter of people who are prescribed opioids misuse them to some extent, and 10% of people develop a bona fide opioid use disorder. And the other important point is to think of, so we're just talking about pills to this point, but the vast majority of people who progress onto heroin or other synthetic opioids started with pills. So to some extent, it's a gateway drug either through a prescription that they received, or you got also think if the market is being flooded, even if people aren't taking these pills, the pills are around. So a mother who gets has oral surgery and gets 30 days of oxy and takes 1 or 2 pills, and all of a sudden you got 28 days of pills in your medicine cabinet. So just the sheer volume of pills that were available was problematic, even if it wasn't to the people who were prescribed. So Sam Quinones wrote a wonderful book. Here, I'll get it. Here's my 2 great books on, you may know this book, Sam Quinones, called Dreamland, a wonderful book. And he also starts with Scioto County, Ohio. I've been to Scioto County, sat down with lovely people there. Great, really great place. And then also this book, Dope Sick, is a fantastic book as well. Careful when you read it. It can make you cry, especially this one. Oh, Lord. I actually got this on tape, and I couldn't even listen to it on tape. I just would be crying on my way because there's these parents just pouring out about their children that, anyway. So just keep that in mind. Keep a Kleenex handy. So Sam Quinones says that this is what he calls a tripartite system of so-called aggressive marketing by pharmaceutical firms, overprescribing by physicians, and at the time lacks government oversight, that especially in Medicaid and professional licensing. I'll mention this. I hope I remember to mention this later in my talk. There were some revisions made to the X waiver yesterday, that I can, maybe Julie knows more, but I'll share a little bit about what I know. It'll be a big deal for prescribing. Again, Texas. All right. So that was a little bit about the things that led to the kind of pill wave, the first wave. There are somewhat different things that led to the second wave. So as prescribing practices became more tamped down in, say 2010-ish, it was sort of like a balloon that was squeezed and the pressure had to go somewhere. Around that time, there were significant changes that were made in the way that heroin was distributed and sold. This historically, most heroin came from Asia, and sales of heroin was very well integrated into use. So the people that sold heroin were the people that used it. And the way they made their money through the supply chain is they would use a little bit and take it and cut it, put something else in there, and then pass along, sell that product and pass it along. And that's how people made their money. So the result is, there's a number of things, that the end product that was sold to, street users, let's say, tend to be relatively weak, right? Because it had been cut along the way. It was somewhat less predictable. I think people didn't quite know what the strength was going to be because it certainly wasn't regulated. And it had kind of a criminal element, if you will, associated with it. If a person wanted to buy heroin, for instance, you can't just call a phone, like it's not like a pizza, right? You just call and say, I'd like 2 bags of heroin and have someone show up at your door. It wasn't ever like that. You would have to kind of ask around and know somebody who knew somebody and, go to maybe an area of town that wasn't so there's a lot of practical barriers even to getting this stuff. But in the early 2000s, the supply chain switched primarily from this Asian heroin to black tar heroin that's now coming from Mexico. And instead of being sold by users, there was this wonderfully efficient system where they would bring in temporary workers from Mexico, illegal workers, bring them in, and it resulted in a more potent product because it wasn't being cut. It was being sold by people who didn't use heroin. They're salespeople or runners. And so it resulted in a flooding the market with a very potent product, a fixed dose product. So you kind of could regulate and you knew what you were getting, or it was like a sort of quality control, if you will, and a fixed price product as well, since it was being sold by people who didn't use the substance. It also tended to be, unlike the olden days, let's say, of heroin sales that tended to be in more, urban areas, coastal areas, urban areas. New heroin started to be sold in more what we call soft targets. And because this was sold by people who otherwise weren't involved criminally and weren't involved in taking drugs, what they did is to go into middle America. So they're avoiding areas like New York or Los Angeles, for instance. Those areas were pretty much controlled by gang activity. But an area like Cleveland presented a kind of really interesting soft target for the drug sales. So instead of targeting the coastal areas or the dense urban areas that were kind of controlled by gangs, now they're going for middle America that's, wasn't ever prepared for anything like this. So the process was fairly simple. So from Dreamland, the book Dreamland, what they would do is they would show up. So there's a group that would show up in a town, and you have sort of one person who was kind of the coordinator, and you'd have 5 or 6 or 7 people who were your temporary workers, illegal workers from Mexico, and they were the runners. And what they would do is they would drive to treatment facilities and methadone clinics, and they would just hand out free samples. Here you go, free samples, along with a card with a phone number, a cell phone number. And the card had a price. You want more? It's $20. Call us in 30 minutes. We'll show up at your house. I mean, it became much more like you think of ordering a pizza. It was very much like that, where you get a free sample, you know how much it is, you know what the dose is, and it can be there in 20 minutes. So in terms of the sales, it just became much more efficient for the user. There were a couple other interesting adaptations, if you will, to the sales process. So we talked about fixed price. We talked about a fixed dose kind of model. And what the delivery boys would do is, these are little balloons there, little water balloons, and you just pack a tiny amount of heroin in there, tie it up like that, so that's your dose. And what they would do is, in the delivery process, they take 3 or 4, whatever the delivery run is, stick them in their cheeks. They call them chipmunks. So you have 3 or 4 of these in your cheeks, and you're just driving, through town, doing your delivery stops. If there's any trouble, for instance, if the police are looking at you or pull you over, all you do is just swallow the balloons. And by the way, it doesn't mean that they're gone. They're still going to use those balloons. You just wait, wait a few hours and, wash them off and use them again. So that was one way. They weren't carrying large doses. They were carrying small doses in their mouths. So you could just, have that option of swallowing. And in any case, the idea was not to carry large enough doses that would result in prison time. So they're carrying small enough doses that the worst case scenario is they're going to be deported. And so they go home, they get a payday with, however many weeks they worked, and, the process continued. Little towns in Mexico, all of a sudden see people come back that have been to the US and spent, 3 or 4 or 5 or 6 months, and show up with, new jeans and a bunch of money. And, it seems like a pretty good gig to people who don't have much going on for them. So that's the way that Sam Quinones describes it. And so fast forward, the result is that overdose deaths from opioids tended to increase just because of the efficiencies in the supply chain. Talking a minute about synthetic deaths, I think I'll just briefly mention. Pretty much, many places, heroin is, it's been overtaken by the synthetics. So fentanyl, carfentanil, some of the other synthetics. In lots of places, there's no heroin anymore. It's all synthetics. That's where we had been having an interesting conversation the last few weeks of whether we ought to be promoting, or whether at a federal level, we ought to be promoting fentanyl test strips. Those are a little piece of paper that you can test the composition of your drug and see if it contains fentanyl. Fentanyl is a much more potent, and it's more, the ratio of effective dose to overdose is very small. So if you don't, either if the manufacturer doesn't know what they're doing or the user doesn't know what's in the pill, that's the result in the, that's resulted in the spike in overdoses. People just get way more than they bargained for. So we've been having this question of whether at a federal level, you ought to encourage people to use fentanyl test strips. You get a pill, you don't know what's in it. Before you take that pill, test it for fentanyl. So I ran this idea by somebody in Portsmouth, Ohio, and they just shook their head and they said, man, it's all fentanyl. There's no heroin. You don't understand. So, and that sort of brought home to me, I thought, well, that's a good point. If 80-90% of pills have fentanyl, and it doesn't test the strength of the fentanyl, it just tells you whether it doesn't really matter because it's all fentanyl anymore. So the work I did in the olden days with college students, where I was a big fan of that because, fentanyl is dangerous. But I think this is sort of a different environment, in which case I'm more skeptical that that's going to help much. Just personal opinion. All right, so the third thing that I want to talk about is just the interesting fact that economic conditions also have a lot to do with opioid use. In particular, things like job loss or wage decline, limited employment prospects, those things affect lots of public health behaviors, but opioids in particular. And you might guess this just by looking at the kind of counties that are, have greater risk of overdose. The percent unemployment is very strongly associated with overdose. So there's just from looking at that here. It's also interesting to look between counties. This is a really interesting study that looked at auto plant closures. So they looked at, this is plants over time, or counties over time. In the blue had a closure right at time 0 there. And the white ones did not have a closure at time 0. And what you see is that, you know, they're pretty, prior to the closure, the counties' overdose rates between the counties look pretty much the same until about a year later when they start to, you know, to separate. So counties that have a manufacturing automobile plant that closes, you know, all of a sudden you see the blue line start to separate from the white line. So that's real problematic there. And so, so what's the solution? I'll tell you about a couple things at a federal level, and then I'll share a little bit about our work on the Healing Community Study. This is the 5-point opioid strategy from the that the FDA developed in cooperation with the CDC and NIH here. I'll focus just on the first pretty much 3 here that my work is involved with. So we'll talk a little bit about access to treatment. We'll talk a little bit about naloxone or Narcan, and we'll talk about a little bit more about surveillance. In particular, maybe I'll comment on a couple of the issues at a federal level regarding surveillance is that there's a terrible data lag. So some states are better than others, but in general, even trying to find out how many people are dying, you know, it may be months and months because you're looking at coroner reports, you know, and so it may be 6 months before you know that whether your state, I mean, so for instance, for Oklahoma, just try and find out what the overdose rates were for, you know, for 2020. I dare you. So probably you get it through the first 6 months, and then, you know, it'll stop about June or July. So it's not like these lovely COVID data that you're seeing in real time. So that's a real issue, is the data lag, just knowing what things are happening in real time. The second thing is there hadn't been much attention to looking at different subgroups of people. And so looking at health disparities, if you want to look at rural versus urban, or you want to look at, you know, African-American versus other populations, it's sometimes difficult to get that data to know which populations are really being effective. And God help you if you live in a small town. You know, if you have a town of 20 or 30,000, it's going to be very difficult to have that data broken down at a local level because the numbers are so small. And some of the data use agreements are going to, you know, have the data suppressed so that you're going to get, you know, really a giant piece of the state when what you want is what's going on in my local town. So there's a lot of work to be done on number 3 there. We'll kind of focus on maybe 1 and 2 here. So the very first one is talking about naloxone or Narcan. This is an important change in recent years. Many states have been recommending making this Narcan or naloxone available. What this does is it's an opioid antagonist. So this has been used for many years to help people who are overdosing in hospitals. And now it's available to the public, where if a person has taken too much of an opioid, if they are given an injection, a naloxone injection, or if they're given now a spray, a nose spray, Narcan nose spray, that can revive somebody who has had an opioid overdose. Now, it will probably work for pills, it'll work for heroin. You may be, though, out of luck if a person is overdosing from fentanyl just because it's much more potent. And so what this does is reverse the effects of an opioid overdose for a period of time so that you can get first responders, take the person to the hospital. So in Texas, at least, a couple years ago now, we have a standing order. So that means that anybody can walk into a pharmacy and just get this with their normal copay. Does Oklahoma have a standing order for Narcan? Can you walk into a pharmacy and get it without a prescription?
You know, I honestly don't know the answer to that.
You could try, just go into your pharmacy and ask them, you know, can I get Narcan? So there are a number of programs. Texas has a program where we just give it to people for free. And it's a SAMHSA funded program out of UT San Antonio. And so I got my box on, you know, I got my box from there. So there's a number of different programs that use this. For instance, are programs like leave behind programs. So if an EMS shows up at a house because of an overdose and they're able to work with the person, revive the person, they might leave behind naloxone or Narcan with a family member, for instance. So that's an example. Another example is what they call co-prescribing. So people that are prescribed a specific combination of, either an opioid or benzodiazepine or a certain dose of an opioid, they might just co-prescribe Narcan with that as well. But anyway, Surgeon General recommends that anyone who works with populations at risk or have any concerns about people that live with you, just have a box of this around. And I've got one in the bathroom there. And I should have brought it. I've got one in the bathroom. I got one in the car, and I got one in my bag. And just because I work with people at the homeless shelter. I have a teenager now. God forbid. So there's no side effects here, and there's not any risk. So that's a recommendation.
I got some good information in the chat that it is something that there is a standing order in Oklahoma, but it sounds like there's designated sites that might be related to Oklahoma Department of Mental Health. They definitely did have a SAMHSA grant for a while supplying Narcan. I believe they still have that, but when these things are federally funded, the funding can change availability pretty quickly.
Yeah. So thank you, Margaret. So again, I'm in Texas, so the place I get it may be different than you. I got it 3 times. I first of all walked into my local pharmacy, into a Walgreens there, and I said, I want Narcan. And they said, here's a box, and it cost me $25. It was my insurance copay. So I got it there. I got it through a state SAMHSA grant through this morenarcanplease.com. And again, they sent it to me, and it was free. And then I got a 3rd dose from naloxone for all. This actually came from New York, and it was a New York program, but they were happy to ship it to me. And it actually came with a nice little card wishing me well, and so anyway, that's where I got mine.
And
so
do you want to talk about the differences in administration for these two? Because I know that people are potentially a little bit more squeamish about injections.
Mm-hmm. Yeah, so the first 2, these are both nasal sprays. It's very much like if you ever use Afrin or anything, it's really a piece of cake. In the middle case and the right case, they want you to do a quick little training program. It's just a video you watch, a 10-minute video online. So most programs now we use the acronym OEND, overdose education and naloxone distribution. So there's the education part, little brief training, and then there's the naloxone part as well. But this is just a up the nose kind of situation. These boxes come with 2. And so you're supposed to give a squirt up the nose and wait, I think, 10 minutes. And if nothing happens, give a second squirt. Oh, sorry, call 911. And then give the first dose, wait 10 minutes, and then give the second dose. That said, yeah, I don't know. He heard an NPR story a few years ago that there was some, the insurance penalty, really, insurance rates went up. Well, then don't use the one on the left. Find your, I didn't report my insurance to the 2 on the right. So, if it bothers you, then use a different program. So that's the first kind of pillar. That's this, naloxone on the bottom. So it's an antagonist. So it's going to block the effects of the opioid. A full agonist, for instance, would be something like methadone. Methadone is an evidence-based treatment as well for people that have a history of opioid abuse, and in particular people who have failed on more modern treatments like buprenorphine, maybe. Methadone is also an evidence-based strategy. So the second thing I want to talk about is buprenorphine. And so this is a medication that can be integrated into, just for example, you might integrate maybe methadone, but probably buprenorphine into jail discharge programs. Now we know that half of prisoners meet criteria for substance use disorder. Opioid use goes largely untreated in the criminal justice system, despite the fact that it's pretty much serving, our jails are pretty much serving as the #1 treatment facility right now, because people get picked up and, so they're essentially detoxing in jail. And so the person's risk of death in the 2 weeks after release from jail is about 12 times more than that of other individuals. Partly because these people are, maybe just at risk in general because they had an untreated drug problem and they get released and start to use again. It's also because of people's tolerance. So if a person is arrested and is waiting, even if there's no crime committed, even if they're waiting to have their court date come up, they may be in jail for, let's say, 30 days. During that time, they're not using, their tolerance has gone down. And so if they get released from jail, all of a sudden their tolerance is low, and they take what was their previous dose, even if it was the same thing. They take their previous dose, but their tolerance is much lower. And that's the risk of an overdose there, because their tolerances go down even though they're taking their former dose. So there are some programs that get people enrolled in medication for opioid use disorder coming out of jail, programs that have patients enroll in medication for opioid use disorder as they're coming out of emergency room when they're there for an overdose or some other related event. And there are very good examples. So for instance, this is just one example of so patients that come out of a emergency room that are prescribed prescribed buprenorphine, show a substantially lower, fewer days of self-reported opioid use in the 30 days after. So, just argues that we ought to be thinking about a emergency department as a, sort of an opportunity for a brief treatment, including medication for opioid use disorder. And we got a lot of opportunity ahead of us. So this is just a map from, I guess it's still from 2017, it's the most recent one I could find. But the red states mean that county had no provider, nobody who was providing medication for opioid use disorder. And so that's a serious problem there. A lot of room for improvement. Now, I will mention that for a long time, there were a lot of practical barriers for prescribers to treat people with medication for MOUD, medication for opioid use disorder. In fact, you needed a special waiver. You had to complete a class. There was a lot more documentation. There were caps on the number of people that you could be maintaining on buprenorphine, for instance. But just yesterday, there's a new federal regulation that takes off a lot of those limits. And so people that have just normal prescribing practices, I think there's a certain cap on the number of, there's still some regulations, and I think there's a cap of 30 patients. But it appears from my reading that you don't need the X waiver anymore to treat a small number of patients if you're sort of a normal prescriber. Anybody know about that? Have you seen that yet? It literally was just yesterday.
The news just started reporting on it today.
So I'll send you the, Julie, if you want, I'll send you, I have the text of it. But there you go. So that's potentially good news, because it means that you can have a lot of people that can be treated with this in more, sort of typical settings, rather than going to a specialist. The third basic pillar from the federal recommendations is controlling just the prescribing and the supply. I'm sure Oklahoma probably has something similar to this, but in Texas last year, for the first time, we had a prescription drug monitoring program, and prescribers and pharmacists were required to use that for patients who were prescribed either a certain dose of opioids or a certain combination of opioids and benzodiazepines or other high-risk categories there. So the idea is to have a kind of a catalog of patients so that you make sure that your patients aren't shopping between pharmacies or shopping between providers. So that's a prescription drug monitoring programs, and many states have those. Take-back programs are another thing that's not particularly controversial. Most of police departments, many pharmacies, libraries take back pills. Our, city building down the street takes back pills in a box like this. And also a lot of room for improvement there. Current take-back programs only about 10% of patients make use of this. So there's a lot of room to move there. The important part here is that we know that the majority of users are getting their pills from, basically diversion, so they're getting them from a medicine cabinet, or, so it's not people, the original reason for those pills isn't the abuse. The original use is they were prescribed for something and they just happen to be sitting around. And so there's a lot of room for, to talk to, good-hearted people, if you will, about look through your cabinet. There's no reason to have all those opioid pills in there. So, put them in a bag, bring them to your library, put them in the, let them go. There are other mechanisms. There's there's this medication disposal thing there. There are other pouches you can order. You put your pills in a pouch, seal it up, and it's got this special stuff in it that dissolves all of it, turns it into sort of a brick of, inorganic stuff, and you can just throw it in the trash. So there's stuff like that you can also do in your home. And Massachusetts is testing an interesting program that actually is paying people to return the unused portion of their prescription. So if they're prescribed, 14 days, they'll actually pay you, they'll pay you $10 to return just whatever's left after you're done using your prescription. However long it is, how many pills you have left, whatever you return, they give you $10. So it's kind of an interesting little pilot test to see whether people would actually want to return their pills. One of the interesting kind of side notes from that is about half of the patients that have returned their pills, taken the $10, about half returned the entire dose, which means that they didn't take any pills at all. I just think is really fascinating. Like, why are we giving people pills and they're not taking any of them? Instead, they would have stuck the whole month's dose in their cabinet for some, enterprising teenager to find. Anyway, I thought that was interesting. And a bunch of other examples. Good Samaritan laws, requiring providers to discuss side effects, special labeling for opioids, abuse deterrent formulations, so that people are taking can't crush or dissolve that. Anyway, so a bunch of other evidence-based examples. And now briefly on the, we're at the end of our time. I'll just show you 2 slides on the Healing Community Study. Yay! So the Healing Community Study is it's the largest implementation science study ever conducted in the field of substance use. We have 67 communities in 4 states, and communities are being randomized to either get a battery of evidence-based implementation strategies. So it's really we're not necessarily testing the evidence-based strategies, we're testing the implementation of evidence-based strategies. It's a little bit of a different way. So half of counties are getting this right now. The other half are going to have to wait till next year. And we're shooting for a 40% reduction. So we're hoping that counties who are in what we call wave 1, get the initial implementation, are going to show a 40% reduction compared to counties that are in the second wave. All of these counties, by the way, are highly impacted counties. All of them have overdose rates of greater than 25 per 100,000. So remember the national average is 15. And so these are very highly impacted counties in Kentucky, Ohio, Massachusetts, and New York. And we're using, we got 10 million people in these counties. Doesn't that blow your mind? It does me. I'm like 10 million people we're working with. That's a pretty good sample size. And so we are implementing these evidence-based domains that I showed you already, naloxone distribution and increasing medication for opioid use disorder, and encouraging safe prescribing and dispensing. And a couple of we also have a communication campaign. So here's we got billboards and stuff on buses. And so we use these things to connect people to these local websites, like down here. And on this local website, they're going to get information about where they can find naloxone in their community and where they can find a prescriber and so forth. We got versions in Spanish. I guess I didn't put any Spanish versions in here. Some of these use local people. So this is a gentleman that happens to be in this county and one of the recovery advocates there. And we're kind of in the thick of implementation and working with COVID. It's been crazy. And so that's the Healing Community Study. If you want to read about it, we got a special issue last month in drug and alcohol dependence. So we got 10 articles that talk about the logic and the design and all the features of the program.